Thank you. So I'm going to give the alternative view on stable coronary disease. So firstly, why is it important? Well, stable angina is extremely common. So this is the situation in the UK. So about 1/3 of a million people in the UK are diagnosed with stable angina every year, and there's 2 million people in the UK who either have or have had angina in the past. So it's a massive problem. The other important thing about stable angina is that 50% of people with stable angina describe their symptoms as very limiting. This has effects on their quality of life, whether they can work. It is a very common and very important disease. So we've got guidelines in the UK from the National Institute for Clinical Excellence, which tell us how we should be managing angina. They say that we should break our management into 3 things. Firstly, we should aim to stop their symptoms. Secondly, we should try and improve their quality of life, get them back to work, etc. And thirdly, what we need to do is identify patients in whom we might be able to improve their long-term outlook, their morbidity and their mortality. And we have 3 tools at our disposal that we can use to do this. Lifestyle advice, I agree, is absolutely essential. They must all lose weight, stop smoking, take some regular exercise. And tablets, again, are essential. We also have revascularization, both percutaneous stenting and bypass surgery. And the guidelines states that what we should do is we should offer optimal drug therapy, and by that they mean 1 or 2 anti-anginals, a beta blocker or a calcium channel blocker at the maximum tolerated dose. I have to say in my clinical practice, a heart rate of 50 isn't tolerated very often with a beta blocker, and appropriate drugs for secondary prevention. And then we should go on and offer revascularization for people with symptoms despite optimal medical therapy. So I'm going to break this down into 2 parts. Firstly, how can percutaneous coronary intervention aim to stop symptoms and improve quality of life? And then I'm going to go on and try and answer the question, can percutaneous coronary intervention improve long-term morbidity and mortality? So, symptoms and quality of life. There is absolutely no doubt that percutaneous coronary intervention is good for symptoms. So this is a analysis of all of the randomized trials between PCI and medical therapy, going back to when PCI, to be honest, was in its infancy, and they clearly show that there is no doubt that in terms of improving patients' quality of life, percutaneous coronary intervention is better than just medical therapy. In terms of reducing angina, it's better than medical therapy, as it is in terms of improving exercise capacity. So if we want to improve people's symptoms, get them back to a healthy, active lifestyle, back to work, etc., percutaneous coronary intervention can help. However, there's always been this question as whether we should be doing percutaneous coronary intervention, and this comes down to a couple of things, really. Firstly, cost. This was an analysis in the BMJ about 8 years ago, saying that even though we know PCI is beneficial in terms of symptoms, should we be doing it? Can we justify it? And that really comes down to this. Does PCI improve outcomes in people with stable coronary disease? Well, cardiovascular disease kills people. I don't think anyone in this room will disagree with that. This is data that we have in the UK. So I work in Portsmouth, which is a city on the south coast of England, where we have particularly high rates of cardiovascular disease. Another way of looking at it here, so this is cardiovascular deaths in people under the age of 74. If you look at the green line in the middle, that's cardiovascular deaths in the UK as a whole, and you can see it is falling. I'd like to think that was due to interventionalists. It's not. It's very largely due to a reduction in smoking levels in the UK. South of England on the whole is a healthy population. The south of England is shown in the sort of orange bar, and men in Portsmouth, where I work, that is the light blue bar on the top. So we have a particular problem where I work. So this is what causes stable coronary disease. So this is coronary atheroma with a lipid-rich plaque in the coronary, a small lumen, but a thick, well-sealed off fibrous plaque keeping things stable. And by very definition, stable coronary disease is not going to kill you. But if you've got stable coronary disease, you have got coronary disease, and we know that coronary disease does kill people. So this is an analysis from about 8 years ago, looking at standardized mortality rates in people who have stable angina and people who don't. And what you can see is, particularly in young people, if you look at the graph on the left-hand side at the top, a woman with symptoms of stable angina, about 50 years old, has a standardized mortality ratio of 12 compared to someone who doesn't. Now that does decrease as you get older, but even in your 80s, if you have stable angina, you are twice as likely to die as someone who doesn't. We also talked about angiography in the last study. The graph at the bottom on the right-hand side shows that if you've got stable angina and a test of ischemia that suggests you have got angina, if you don't have an angiogram, again, you've almost got twice the risk of dying as if you do have an angiogram. So people with stable coronary disease, it's not like a stable coronary disease that kills them, but cardiovascular disease is very likely to kill them. We've touched on the COURAGE trial, and as you can see here, there is no difference in the primary endpoint here between optimal medical therapy alone and optimal medical therapy and PCI. However, what COURAGE doesn't tell you is how to manage the general population with stable coronary disease. COURAGE is a very, very carefully selected low-risk group. You can see, for example, with the exclusion criteria on the right-hand side here, about 85 to 90% of patients were excluded, and you were excluded, for example, if you had severe coronary disease. You were excluded if you had severe angina. All of those people who we intuitively think would benefit from most from revascularization. And even in that very, very carefully selected low-risk group, they found groups that did appear to benefit from revascularization. There was a nuclear substudy looking at reduction in ischemia. And what they showed is that if you could reduce ischemia, you had a significant benefit on mortality. Hard endpoints. And in fact, the more you could reduce ischemia, the bigger the effect you had on mortality and infarcts. To the extent that if you left the patient with no residual ischemia in this analysis, you had zero risk of infarct or death, compared to if you had more than 10% of your myocardium still ischemic, you had a 40% risk of an infarct or death. So, these are the European guidelines on who we should be revascularizing in stable angina. So, there is a Class 1A indication for revascularizing anyone who has got a significant left main stem lesion. There's a Class 1A indication for revascularizing anyone with a significant proximal LAD lesion, etc. So I think there are certainly people who would benefit from revascularization despite having stable angina. The next question is how we should go on and do revascularization. This is what's happening in the UK. So the numbers of people undergoing bypass surgery is staying about the same, whereas the number of people undergoing percutaneous coronary intervention is going up dramatically. We now do about 6 percutaneous coronary interventions for each one patient going for bypass surgery. Why is that? Well, I'd like to think we are responsible as interventionalists, and the rates of percutaneous coronary intervention that we're doing for so-called stable coronary artery disease are decreasing. That's partly because stable coronary disease doesn't present to us very much. People tend to present to us if their symptoms are getting worse, if it's a new presentation, etc., which by definition is not stable. The other thing is we have got increasing rates of interventions for acute coronary syndromes, and you can see here a decrease in the numbers of procedures we're actually doing for stable coronary disease. To show it another way, this is what we're doing in the UK, so increasing numbers of primary PCI for ST elevation myocardial infarction, that's what keeps me up at night. About the same number for non-primary ACS, and decreasing numbers of procedures for stable angina. So I think when we're considering the method of revascularization, we need to consider multiple different factors. We need to consider their coronary anatomy, whether they're diabetic, what their comorbidities are, their surgical risk, the risks of antiplatelet therapies if we're going to go on and put in a stent, whether they would require anticoagulation for another reason, such as atrial fibrillation. Patient preference is important, and also, particularly in some healthcare economies, cost. We're very lucky in the UK where drug-eluting stents cost about a quarter of what they cost you. Now, you can't talk about method of revascularization without briefly mentioning the Syntax trial. This was a trial looking at Taxus drug-eluting stents versus bypass surgery in people with multivessel disease. This is the very brief trial design. So there was a randomized section with people who were considered eligible for both PCI or bypass surgery, and 2 registry arms with people who weren't considered suitable for both treatments. Syntax was important not just for the results, but also for 2 things. One was the formation, just to go back one here, of the heart team, what we would describe as a multidisciplinary heart team comprising both interventionalists, hopefully non-interventionalists, and surgeons to decide on the best method of revascularization. And the second way it was very important, other than the results, was in the development of the Syntax score. This is a method of of objective assessment of the severity and extent of coronary disease. So this is the primary outcome result from Syntax, looking at a composite of all-cause death, cerebrovascular accident or MI at 12 months, and there was no particular difference between bypass surgery or PCI. However, there were dramatically increased risks of a repeat procedure in people who had stenting. The only thing in favor of stenting, to be honest, was a slight reduction in the risk of stroke compared to bypass surgery. The results now have been extended out to 4 and 5 years and do show that there are certainly patients who are still best served by bypass surgery. For example, people with 3-vessel disease and diabetes. But the take-home message from Syntax really was the need for this discussion about cases in a multidisciplinary way. So these are the European guidelines on how we should be managing people with stable coronary disease. So just to run through them quickly, if you have 3-vessel disease and a Syntax score of over 23, which is a moderate or high Syntax score according to the Syntax trial, you're probably best off with bypass surgery, and if you're low surgical risk, following discussion in an MDT, you should go on and have surgery. On the other hand, if you've got 1 or 2 vessel disease, particularly if there's no proximal LAD involvement, this is probably a case for percutaneous coronary intervention. And hopefully, following discussion, we discuss every single case for revascularization for stable coronary disease in our unit. They should go on and have PCI. But integral to this is the heart team discussion. There's a similar thing for left main coronary disease here. So if you've got left main plus 1 disease, particularly if it's in the ostial left main or in the shaft of the left main, probably a PCI case. Following appropriate discussion, go on and perform PCI. Whereas if they've got left main and 3-vessel disease, particularly if they've got a moderate or high Syntax score, this should be a surgical case and go on to bypass surgery. However, with intervention, we are certainly catching up with bypass surgery. So this is an analysis just published a couple of weeks ago, looking at diabetics with 3-vessel coronary disease randomized to either bypass surgery, the gold standard, and I would say still the best treatment, or Everolimus eluting new stents. And this shows hard endpoints of death followed up for several years. And to be honest, whilst there is still a significant difference between bypass surgery and Everolimus eluting stents, if you were to show this graph to many patients and say you can either have an operation or a stenting, I suspect that many of our patients would say, actually, I would prefer to have stenting. I will accept that tiny worse outcome and the need for increased revascularization with stenting. If you are going to go on and do stenting, particularly for stable coronary disease, you do need to do it responsibly and well. This is the results of the FAME study, a study looking at multi-vessel disease and the use of fractional flow reserve, calculated using pressure wire assessment. And what this shows is that by using pressure wire assessment, you could change the way you manage patients. Do less stenting, for example. Avoid stenting altogether in some patients. What this shows is quality of life adjusted life years on the x-axis and cost on the right axis. So this is what we call a bootstrap analysis. And what they showed is that out of 1,000 patients, 998 they could show they improved outcome and reduced cost by using pressure wire evaluation. So there is no excuse for not using pressure wire evaluation for multi-vessel coronary disease these days. I was also involved in a study called the Ripcord trial, which looked at management using the pressure wire at the time of diagnostic angiography. And what that showed is that in 1/3 of cases, using the pressure wire measurements led to a change in management from what you would have done just looking at the angiogram. And that included people who would have been sent for bypass surgery with 3-vessel disease ending up having 1 stent or even no stents, and similarly people who would have ended up being referred for a stent ending up with bypass surgery. And if you're going to do PCI, you need to do it properly. To be honest, I suspect one of the reasons why in the past we've been unable to show a benefit from PCI is because we've been doing it badly. We know that using tools such as intravascular ultrasound on the upper left, OCT on the upper right, can dramatically improve our long-term outcomes from stenting by optimizing our stent results. Similarly, proper lesion preparation with things like rotablation, which you can see on the bottom, essential in terms of obtaining good long-term outcomes. And in this day and age, we should be doing PCI radially. So there are some patients in whom it is particularly preferable to go radial. Radial is associated with at least a halving of vascular access problems. It also means that you can get the patient walking off the table at the end of the day, at the end of the case, and that means that for elective angiography, we can reduce costs by doing all of these procedures as a day case. So this is the number of day case interventions in the UK, so it's now up to about 20% of all of the PCIs that we do. In Portsmouth, 20% of our PCI is elective, and 20% of our PCI is day case. We're even doing day case acute coronary syndrome PCI now. This is what I wish our hospital looked like. So this is a radial lounge in a hospital in the Netherlands. If you look at the picture in the bottom right, you can just about see the reclining chairs where the patients go after their procedures for the first half an hour or so before they go and sit around the table and have a coffee for a couple of hours before they go home. Tea, it would be here, I'm sure. So in conclusion, firstly, All of these cases need to be discussed in an MDT. It is irresponsible to just get on and do intervention in stable coronary disease without discussing it first. I think that we should be considering revascularization in people in stable coronary disease who have ongoing symptoms despite medical therapy. That's what's recommended in the UK guidelines. But I also think it is essential to offer revascularization to those people who have high-risk coronary anatomy, so left main disease, three-vessel disease, significant proximal LAD disease, and that means you need to do an angiogram. You also need to offer revascularization to those people with a significant ischemic burden. Now, whether that is calculated using pressure wire evaluation at the time of diagnostic angiography or with a functional test, if they have more than 10% of their myocardium ischemic, you are going to do them prognostic benefit from revascularization. You then need to decide on the method of revascularization. That's where the MDT comes in. And I think it is very largely dependent on the syntax score, the objective evidence of their coronary anatomy, whether they've got diabetes. You also need to take into account their comorbidities, their surgical risk, and the risks of PCI, which are largely down to the risks of antiplatelet therapy. And I think patient preference, particularly in the UK, is having an increasing impact on how we revascularize patients. And if you go on and do PCI, you need to do it well. So firstly, you need to consent the patients properly. They need to be aware, are you doing this for symptoms? Are you doing this for prognosis? In this day and age, with multi-vessel disease, we should be using pressure wire evaluation. Should certainly have a low threshold for using intravascular imaging, and we mustn't forget that we need to pay attention to the medical therapy. We don't get rid of coronary disease with PCI, we just push it out the way. So you can't stop the tablets, and similarly, lifestyle measures are still absolutely crucial. To go back to the COURAGE study, I would like to put things very differently. What I would suggest is that it is safe to manage very carefully selected low-risk patients with stable coronary disease medically. But I suspect that's a minority. Thank you very much.